Respiratory Syncytial Virus, RSV, is the leading worldwide cause of acute respiratory illness in children under 5 years, with over 6 million RSV wheezing or pneumonia cases and over 100,000 deaths occurring each year. Most of these deaths occur in children under 6 months of age, and 90% or more occur in low-income settings. We've seen remarkable progress in the development of products to prevent RSV disease in infants. In 2023, the first approvals were given for 2 highly effective products that prevent severe RSV disease in young infants. RSV-Preef, Abrysvo, a vaccine given to pregnant people to boost RSV antibody and protect infants through transplacental antibody transfer, and nirsevimab, Beyfortus, a long-acting monoclonal antibody given to infants at birth or in the first few months of life. As of today, one or both of these products have been approved in over 50 high-income and middle-income countries and in India, but not yet in any other low or low-middle-income countries, nor in any African countries. Our paper presents case studies from 3 regions or countries, Galicia and Spain, Argentina, and Kenya, to illustrate current use in the case of Spain and Argentina, and future thinking in Kenya about these products. Galicia and Argentina have achieved remarkable success in introduction of either nirsevimab or RSV-Preef through coordinated efforts by policymakers, professional societies, and the media. Kenya has yet to approve either nirsevimab or RSV-Preef, but has been thinking about opportunities and challenges related to implementation. Every country should ultimately have the opportunity to select the type of intervention, maternal immunization, or long-acting monoclonal antibody that best fits the needs of its population and its health system. Efforts are underway to assure that the RSV-Preef maternal vaccine is available, affordable, and acceptable worldwide, including in low-resource settings. However, to our knowledge, no such efforts have been made to ensure global availability of an RSV infant monoclonal antibody. As a matter of global equity, both RSV maternal vaccine and RSV monoclonal antibody should be globally available at affordable prices. For the first time since RSV was discovered over 67 years ago, we have the ability to prevent severe RSV disease in young infants everywhere. It is incumbent upon the global community to turn this opportunity into a reality, especially in settings where the need is greatest and interventions have often arrived last.
RSV is the second most common cause of death in infants after malaria. The worldwide burden of RSV is inequitably distributed. All children are infected with RSV by the age of 2, but only 1 in 50 develop severe RSV, amounting to 33 million episodes globally of lower respiratory tract infection every year. Although most infants with severe RSV are born term and previously healthy, nearly 1 in 6 children have a severe comorbidity. Severe RSV presents as 3 age-related clinical syndromes: sepsis in neonates, the very young, bronchiolitis in infants, and pneumonia in children. There is still no widely implemented clinical tool to help clinicians predict which children will go on to develop more severe RSV. Most infants with RSV are asymptomatic or have a mild cold. RSV follows the north-south route to progress to more severe disease, manifesting with upper respiratory tract symptoms such as a runny nose before progressing down to the pulmonary symptoms. There's no evidence-based treatment for RSV. The cornerstone of hospital management is supportive care through respiratory support and fluid hydration. Oxygen therapy is the mainstay of management. Respiratory support can be life-saving in the case of respiratory failure. Lack of intensive care availability is associated with high mortality in low-resource settings. High-flow nasal cannula therapy, or HFNC, has been adopted widely in the past 10 years. In this manuscript, we show that there is no efficacy against life-threatening RSV disease. Moreover, there is a trend towards increased ICU admissions and intubations after HFNC use, which is alarming and supports the removal of high-flow nasal cannula from standard RSV care. As antivirals are not yet available, prevention for RSV is key. We are in an exciting new chapter as RSV can now be considered a vaccine-preventable disease. On the road to universal immunization, high-risk groups, especially in low-resource settings, should be prioritized as an interim strategy.
The new vaccine given to pregnant women, the long-acting monoclonal antibody given to infants and high-risk children are highly effective for preventing early life RSV disease. However, RSV in early life has also been associated with development of subsequent illnesses. An important question is whether prevention or delay of RSV in early life through these new effective products may prevent or ameliorate the development of associated subsequent illness. So which illnesses may follow RSV and what is the mechanism for these? Firstly, early life RSV may predispose children to subsequent infections such as ear infections or pneumonia. Secondly, early life RSV, especially when severe, has been associated with the development of recurrent wheezing or asthma. This is a complex relationship involving interactions that depend on the genetic makeup of the child, the age at which RSV is first experienced, and interactions with other environmental risk factors such as tobacco smoke exposure. Finally, early life RSV may lead to impairment of lung function, a measure of respiratory health. We know that lung function tracks over the course of life and is a risk marker for premature mortality. So impairment in early life may have lifelong consequences for health. Birth cohort studies show that lung function impairment measured shortly after birth predisposes a child to developing severe RSV. However, RSV disease itself and all-cause pneumonia directly impair lung function, leading to stiffer lungs and obstructed airflow independent of pre-existing lung function. Infancy is, of course, a crucial period of lung and immune development. Possible ways in which early life RSV may contribute to the development of such chronic illnesses include direct damage to the epithelium lining the airways, altered immune responses with inflammation that may predispose to asthma, and changes in the composition of the airway microbiome. Will the new RSV preventive interventions help against development of associated long-term disease? Well, we don't know. But given that RSV may have both short and long-term health impacts, the full public health value of these new RSV preventive products is likely greater than that measured by early life RSV disease. It will be important to study the impact of prevention or delay of RSV disease on these associated long-term illnesses. Understanding this impact is key to designing successful prevention strategies that may prevent such long-term illness. The potential for preventing these further underscores the urgency for access and availability of these new interventions to prevent early life RSV disease in children, especially in low and middle income countries.
RSV is a well-recognized pathogen in children, but it is also important to recognize its impact on adults, especially in older age and for those with other underlying diseases. RSV is common. It's estimated that 3 to 7% of older adults suffer symptoms from RSV every year, and around a quarter of them will seek medical attention. Usually, RSV in adults causes a mild and self-limiting upper respiratory tract infection, but around 1 in 8 of those who seek medical care will need admission to hospital. This risk of hospitalization is much higher if somebody has another condition such as COPD or heart failure, and in these people, the symptoms often relate more to worsening of the underlying condition rather than the typical symptoms of a respiratory tract infection. Other groups at higher risk are those with poor immunity and the very elderly. Compared to influenza, people admitted to hospital with RSV tend to be older, more frail, and have more underlying diseases. As a result, they generally stay in hospital for longer and have poorer outcomes, including a high rate of complications. These complications can be early, like heart attacks or confusion, or late, such as loss of function and independence. People with immune deficiency have specific and serious risks from RSV. For example, infection can cause significant and irreversible damage to transplanted lungs, while some people cannot clear the virus for weeks or even months. As a result, the annual cost of care is estimated to be similar for influenza and RSV, and this runs into billions of dollars in the US alone. And yet, while everyone has heard of the flu, how many people know about RSV? Fortunately, there are reasons to be optimistic about RSV in adults. The recently approved vaccines seem to be effective in clinical trials. It's hoped that these will bring down the number and the severity of infections considerably. Antiviral drug development has been accelerated with the COVID-19 pandemic, and there may be new drugs on the horizon. We're also increasingly seeing point-of-care tests being used. You can tell GPs or other healthcare providers whether somebody has RSV or another virus like flu or COVID-19. This could help get them the right support and care straight away. The social distancing measures taken in response to the COVID-19 pandemic really reduced RSV infections as well, so we can hopefully learn from this to protect the most vulnerable adults in our society, especially those living in care homes. There are still things we don't know. How well will the vaccines work in the very elderly, for example those aged over 80 or 85, and in those with underlying health conditions? What can we do for people who don't respond to vaccines because they have immune deficiency? What are the consequences of the really long infections we see in those with poor immunity? For example, does the virus evolve to form new variants? Who needs antiviral drugs? Which ones should we use? RSV is a really important infection in adults who are older or have other diseases, and we need to take it seriously at all ages.